So in terms of, I don't follow too many patients with bypass grafts, but in terms of endovascular, I typically do surveillance at 1, 3, 6, and then annually, particularly for SFA or if they have for stents. And I tend, as Josh pointed out, to intervene early, even if they're asymptomatic, because I think once a stent goes down, or once the artery goes down, it's much harder to get open than if you have a 70% lesion to just balloon it open, or maybe in modern era use drug-coated balloon or something along those lines. And in terms of medical therapy, I for a stent, or even after a stent, it's 1 month. I typically do 1 month of dual antiplatelet therapy, whether so typically clopidogrel and aspirin. I guess you could use some of the newer antiplatelet agents if they have a contraindication to clopidogrel, and then thereafter just aspirin. I don't typically use anticoagulation.
Yeah, I think from a follow-up standpoint, I don't have anything else to add. From a medical management standpoint, I do at least any types of stent or below-the-knee bypass. I think there's a little bit of data for prosthetic bypasses and stronger antiplatelet therapy, and with autologous tissue bypasses using formal anticoagulation along with a baby aspirin. As far as endovascular procedures, all of those patients are sent out on Plavix and baby aspirin if they'll tolerate it. And I've kind of evolved from the standpoint of initially doing 1 to 3 months of Plavix to, if they're tolerating it well, I keep them on it. If I've got a patent stent and they're doing okay, not having significant bruising, any other issues with the Plavix, I keep them on both of them.
I just want to make a comment about the perineal versus pedal. In our early experience many years ago of all of our perineal artery bypasses, we could keep the patients with end-stage renal disease. We could keep their perineal bypasses open, but often it didn't actually perfuse their foot enough to heal the foot. So we preferentially went to the pedal vessels in these patients with end-stage renal disease, but that's not a universal opinion. So I didn't know if does the panel have any other comments on any of these other topics? We could go on for a long time about each one of these, but y'all want to pick out one more thing to make a comment on?
A quick thing on the perineal versus pedal. So we've tried to get this published in JVS, but they turned it down. But anyway, there's a definite syndrome in renal failure patients that we nicknamed orphan heel syndrome. And they frequently will have a palpable dorsalis pedis pulse, normal 4-foot waveforms, and they have a heel sore. And you angio them, and their perineal and posterior tibial arteries are diseased. And if you don't get blood flow to the heel, their heel is actually ischemic. So I think those are the subgroups of patients where we try really hard to do something to perfuse the wound, and not just, we used to for years do a bypass to whatever was open, and it seemed like it worked most of the time. But I think our patients have changed. So those renal failure patients, if you actually angio them, even a small heel ulcer, it's like a syndrome. If you look at it, they all have poor perfusion to the heel, and a lot of them still have pretty good preserved 4-foot perfusion. So I think that's, when you get a heel ulcer, think ischemia.
Good. All right. This is the lesson. I don't know if anybody's seen Galaxy Quest, but when it comes to pedal bypass, never give up, never surrender. So next case, 78-year-old gentleman with leg pain who comes in with swelling of his leg, and he thought it was all related to his statins. He denies hypertension, hyperlipidemia, or diabetes, although he's on Carvedilol and Allopril and Lipitor. So it raises the question whether he's a little demented or has a little denial. He is a former smoker, but he quit over 25 years ago, and he has coronary artery disease, having had a coronary artery stent in 1986 after an MI, and had an ICD placed in a couple of years ago as well. So he comes in with a small lesion at the tip of his left great toe. He has diminished femoral pulses, none distally, with dependent rubor. And his ABI is 0.30 with no detectable toe pressure. Audience, based on this scenario, pick one of these. CT imaging, primary toe amputation imaging with DSA, or no intervention at this time. All right, so most people would go to C, looks like. Somebody changed their answer. Not fair. All right. So most people would go with a regular angio. In this case, he actually, can we make this work? Can you run through this? Yeah. I think you'll see that he has a significant amount of distal aortic disease, especially on the left side, which is the symptomatic side. You can go through there. And then he also looks like his right external is patent but diseased. And then he's got this chunk of stuff in the external and the common femoral on the left side. I don't think I can go back. Let me see if I can stop this and go back. I don't know if I can't make this go back. I'm out of control there. So he was placed on Celestol for a couple of months. He said, "Doc, I don't want an operation. I'm not really having that much pain. I don't want you to do anything right now. I think I can get by." So he comes back in a couple of months, and now he missed his first follow-up appointment in 1 month, and he comes back in 2 months, and now his lesion is 10 millimeters. He still denies any rest pain or any limiting symptoms. His creatinine is 0.9, and his ABI is still low. And this just is to refresh the picture of the same scan that you'd seen before, and a lot of aortoiliac occlusive disease with a lot of disease at the common femoral on the left side as well. So now, based on this CT, what would you do? Left femoral endarterectomy, hybrid procedure, aortofemoral bypass, diagnostic angiogram and iliac stent only, or no intervention at this time? All right, most people would go to, I think that's a hybrid procedure, isn't it? Yeah. Yep. Okay. Back. So he had an attempted angiogram through the right side to try and do this, but then it was unsuccessful, as you can see, where the external iliac totally occluded. Had a lot of disease in the left common iliac, and actually just underwent a stent at that time because he said, "Doc, I don't want an operation if you can help it." And you say, "Well, I don't think it's likely to help you, but we'll see what we can do." And this is the pictures that you had, and his distal runoff shows the SFA is patent with popliteal occlusion, and then very poor visualization, but this is the distal runoff on the left side. And you might be able to see something come in very faintly down here. Maybe the popliteal reconstitutes down there. So at that time, he underwent only a left iliac angioplasty, and not surprisingly, his ABI didn't improve. And you tell him, well, we've got to do something. So he's admitted for a left femoral endarterectomy and integrated SFA and popliteal angioplasty, since he didn't have any improvement in his ABI. So you bring him back in a few days later. Let's see here. Can we go to the... Can we run this? There we go. He had a lot of plaque in the common femoral. You placed an interposition PTFE graft instead of doing just an endarterectomy and a patch angioplasty. And you're able to get something into the SFA, and you placed an 8-French sheath into the SFA. And so this is the picture that you get at this time. You're able to get down and you hammer away at the distal SFA, and you try a various number of techniques V18, you try glide catheters, glide wires, unable to get anything to cross here. And in fact, on the far right, you can see you actually have some extravasation. So at this point, who would press on here? Would you persist? Access to pedal vessels at this time? Would you, through a retrograde approach, or come back another day? Would you plan to, when he comes back, to go ahead and schedule a fem pop or prosthetic graft because he doesn't have any vein on that side? Or would you rely only on your iliofemoral reconstruction for limb salvage? Can we go to the clickers? Okay, looks like C has most of it. All right. So most people would reschedule for a prosthetic fem pop bypass. Now that doesn't really fit with the theme of the conference, does it? So it's interesting. I'd like to get some comments from the group here. How many would come? Would you guys come back another day, or would you just kind of press ahead? You know, you're 2 hours into this. You tried to go up the right side. You know, you're done an endarterectomy. I'm sorry, this time you just done an endarterectomy and a patch. You dug out the groin. You've gone to a lot of trouble to get this down there. Would you go ahead and pursue this? You've been at it for 2 or 3 hours. Let's go right down the line here.
Okay. I absolutely would. I think if you go back to your diagnostic, just the diagnostic pictures, you actually have reconstitution of, I think, what looks like the AT on the below knee arteriogram. And as I described yesterday during our case conference, I think accessing retrograde and running a V18 wire back to, while you've got the femoral open and exposed and have an arteriotomy there, you have a lot better chances of being able to cross that occlusion and that lesion in a retrograde fashion than you do in an anterior or in an antegrade fashion. So I would continue to try at that point, as long as you still had a distal target on your arteriogram.
Dr. Mills?
Yeah, I think I would have tried to convince the guy to have one operation up front, because when you have that much common femoral plaque, it's basically occlusion. Even if you can get the stent in safely, you've got that other flow-limiting thing that doesn't allow flow into his profunda and SFA. So if I could have talked him into that, I would have tried to fix that in his iliac. And then I would have predicted if his ABI was 0.3 before, you could probably get it to about 0.5, 0.6, and that might be enough to heal a tiny foot ulcer. So what's his foot look like now?
He actually has a sore on about a centimeter sore at the tip of his great toe.
So here the issue is one, that retrograde will help you to some extent, but part of your problem is a rock there. And even when you come from the other way, it's still a rock. So the reentry part sometimes helps you when you go retrograde, if you've actually got by the lesion and you're having a hard time reentering. But if you have a really hard time crossing, sometimes because that stuff is just like a rock, it's going to be a rock whether you approach it from the top or the bottom. So you still may have trouble with that. So I think at this point in this procedure, I would have stopped and then reassess my perfusion after my femoral procedure and iliac stent and just see what you get.
Mm-hmm. Tom?
Yeah, I agree. I think if we treated, I guess, 2 segments, there's a good chance that you may heal. I think at this point you've already perforated, you've created a dissection plane, so your chance of reentry is diminishing. I probably would let this heal, or have him come back, check his pressures. If he needed to come back, give him enough time to heal this dissection, and then you're going to go again, probably up and over, and go antegrade, try it antegrade, maybe quickly, and if you can't cross, then retrograde.
Yeah, I think we're a big fan of the hybrid procedure, the femoral endarterectomy, and try and do as much as you can through an endarterectomized femoral artery, both retrograde up in the common iliac, whatever needs to be done to get your inflow, and then try and do something straightforward or simple distally as well if it's necessary, especially if you got tissue necrosis in the foot. I think we're pretty aggressive about trying to establish inline flow. So let's skip ahead here.
Can I ask a question?
Absolutely.
I don't think you've got a good enough picture of the circulation at the knee and below.
Yeah.
I think we thought we saw a popliteal, but now you've got pretty good flow. Get a better angiogram and then decide what to do.
Yeah, that last image was taken intraoperatively during the time that you're trying to cross the SFA and try and get a good picture. And you do see the popliteal come in, but it's very hard to see very much of his distal runoff. So he was discharged with a stable gangrenous toe eschar. You did improve his ABI, but he still has no toe pressure. He still has dependent rubor. And he still isn't having very much in the way of rest pain. He says, "Doc, I don't know if I need to do anything with this. It looks like it's getting better to me." But he came back in. He now has exposed distal phalanx, and clearly something has to be done. So he had antegrade 4-French access through both his PTFE graft and via the dorsalis pedis using ultrasound guidance. And this is the retrograde picture that you're able to get. You can see total occlusion there, and actually this is the proximal portion of the popliteal all through here. It does show that his runoff is better than you could have anticipated. And through the Safari technique, you're able to pass a V18 wire all the way up into the superficial femoral artery and retrieve it. And it was exchanged for a V18, which is snared, and then we were able to do a PTA with a PTFE covered stent, and this is the picture. But as Dr. Mills said, there's a lot of rock. There's a coral reef in there, and it actually, in order to get satisfactory expansion of that, actually had to have a balloon expandable stent. So he came back and had his exposed bone snipped off with a toenail clipper in the clinic. And at 5 months, it's totally healed, and his dependent rubor is resolved, and his toe pressure is now 32 millimeters of mercury. So any tips or tricks from the panelists in terms of this retrograde Safari technique? Yeah, all have any suggestions? Should it only be used for tibial occlusions, or all SFA occlusions you can't cross, popliteal occlusions? Comments from the group? Anything? Tom?
There are some people who, probably strictly endovascular folks who are really doing this kind of first pass. I personally will try it if I can't go for SFA popliteal. If I cannot go antegrade and can't re-enter or that. But I know there are a group of people, increasing numbers of people who just start off right off the bat and they go pedal. There are even some groups that then have kind of streamlined it such that, they go, when they do a lot of radial artery caths, and they actually put they've kind of streamlined it that way and put a TR band on the ankle, and kind of that's their approach. I personally don't do that. I think I use it for failed, if it is a claudicant, it failed, and make sure that there's at least 2 vessel runoff.
So you have, for people that have claudication and a SFA occlusion that can't be crossed, pedal access is good. Dr. Adams, you come from the mecca of Safari land.
I guess my practice has totally evolved from the standpoint of only doing this for patients who have significant tissue loss or rest pain, and we're doing this as part of mostly a total endovascular procedure in the angio suite for limb salvage. to the point where now what I've found as I've used this retrograde access and crossing lesions in a retrograde fashion is that it's often much, much easier to cross these lesions retrograde than it is antegrade. I've even had a couple, the calcified nature of this lesion, I've been able to cross with a V18 that stays in a straight tip, suggesting that you've actually stayed intraluminal coming retrograde, which would at least at that point allow you the opportunity to do some debulking atherectomy of that heavily calcified lesion to change the wall compliance and likely still end up needing to stent it, but with balloon angioplasty and stenting afterwards by debulking the calcified lesion, that it can help with your long-term patency. And as I described yesterday, I think when you have the femoral open, running a wire retrograde back to your femoral endarterectomy is a much more efficient way to get a wire going down and to intervene distally to your femoral, because you don't have to worry about tacking down an endpoint. You can very almost barbarically just bluntly dissect in that subintimal plane and create a nice long large landing zone for your anticipated stent in the proximal SFA, and that way not have to worry about extending up and obstructing the profunda at all with your
Great. Thank you.
intervention.
Good. Scott Stevens.
Jay, I like the idea of separating inflow and outflow procedures, and your case showed it well. By the time you've accomplished inflow, the team is fatigued, the wires are sticky, you've hit contrast limits, the patient's getting a little fidgety, my circulator is calling her daycare saying she's going to be late to pick up her kids, and it's a hard time to start a technically demanding tibial work. And also you can make the patient worse. If you scuff up some of the important collaterals, you might turn critical ischemia into acute ischemia, and now you're in a row bind. If you can separate them, sometimes the inflow is enough to heal it, and when it's not, as in this case, you come back prepared, and now you're on path, and you have a winning philosophy instead of a bailout philosophy. I'll prep out the whole leg so I can move up and down with my ultrasound and have my full range of options. So I like to separate the two.
Thank you very much for your comments. Dr. Hallett, did you want to make a quick comment?
There's some new options that are in clinical trials which are finishing up now, and one is the bone marrow stem cell transplant clinical trials, and there are a number of those. Any thoughts on those clinical trials? I think at least one of these patients we probably would have put to that trial before we did anything else. And then what are your thoughts, and maybe Tom, you can comment on this. Tom Rook up at Mayo has been talking a lot to me about intermittent pneumatic compression in ischemic limbs to stimulate collateralization and flow. I've not done it, but there's some other options now that people are looking at that you've not discussed in this panel.
Yeah, I think those both have huge potential. The problem is the intermittent compression for me has not worked once they get tissue loss. And I think the problem with all the cell-based therapies is the way we're forced to do the trials has generally been on patients with no other option. And I think that's a bad group to study. I think the patients that might do the best are these little frail people that we all see that have a small wound that just won't heal. And it appears not to get infected. They're somehow resilient, but they keep coming back and they have a little bit of rest pain in the small wound. To me, those would be the ideal patients to study because you have time. One comment I wanted to make related to those SFA lesions, I don't know what the best thing to use is. When you get them open, you have to put a stent in. So our group's kind of split. Half the group uses Supera stents, which are woven, and they're really strong. The other half uses a Viabond and then just blows the balloon up to a really high pressure to try to crack everything. I think you need to do one of those because if you don't crack that calcium, it's not going to work.
Yeah, good point. Well, we have another case to discuss, but we're running out of time. So if anybody wants to come see me, and we'll go over that case together personally, but I don't want to keep everybody beyond their time, and I think we're running out of time. And I appreciate the panel discussants, and I appreciate the audience participation, too. You all add a lot to that. So thank you very much.